All right. Good morning, everybody. Thank you so much for the invite to talk. My name is Kristen Stabingus. I am the newest member of the Pediatric Neurosurgery Squad over at Nicholas. And as of this week, I now have my privileges here at Jackson. So coming to a call schedule near you very soon. I'm actually going to be talking about something a little different today. I figured, in this room of neurosurgery giants, there's not a whole lot about surgical technique that I'm going to have to offer. But this is something that I think is really important, and I hope that at the end of this, everybody can appreciate why this topic needs more attention. And so I'm going to be talking about healthcare transition in pediatric neurosurgery, and what I mean by that is the transition from pediatric centered care to adult centered care. So since a lot of you don't know me, I figured I would do a little background first. I'm originally from Philadelphia, outside of Philly. I went to medical school in Philly and then made my way across the state to Pittsburgh, where I did my neurosurgery residency at a place called Allegheny General Hospital, which when people think of Pittsburgh and neurosurgery, they think of our evil stepsister, UPMC. But we actually share the neurosurgery scene pretty equally, I would say. And I spent my early years of residency very much like you guys are in conference right now with people like Peter Janetta and Haedong Jo. And we actually, our pediatrics rotation is done at Children's of Pittsburgh, which is a hospital that we share with UPMC. So I learned pediatric neurosurgery from people like Ian Pollock, who wrote the book on pediatric neurosurgery, and that's where I fell in love with peds. Originally, I actually had no interest in going into peds, and then things changed. So Pittsburgh, as you know, is an interesting city. We are known for our incredible diet culture, where we put French fries on sandwiches, which is, makes for a really healthy patient population, which is great. And then after I finished residency, I made my way down the coast a little bit to Children's National, which is a pediatric hospital in Washington, D.C. And a little bit unique in the education there in that we actually have residents from Georgetown, from GW, from Inova, and also from Walter Reed. So we have a ton of residents that rotate through. And I trained with 5 incredible mentors who are in that awkward photo at the bottom there. And the reason this was actually my top choice for fellowship, and the reason being is because I have an interest in brachial plexus surgery. And as I'm sure a lot of you know, plexus surgery and neurosurgery is kind of a dying field, not here, but in pediatrics. And so as my chairman at Children's National has still a pretty busy plexus practice, which was the whole reason that I wanted to end up there so I could carry that on and build my own practice one day. So I don't have any financial disclosures for this talk, but I have one very important disclosure that everybody needs to understand. And that is that I totally love shunts. And it's very important that you recognize this because I think all neurosurgeons have a little bit of pathology, but if you own it, it's okay. So this is my pathology, and I think all of you have to appreciate that about me. And now that you know that, there's no secrets. And it's funny because I saw that Dr. Abla is doing a talk after this on basilar brainstem bypass, which was actually my second choice of topic. So I was going to give that exact same talk. So that would have been so weird. But some people say that shunts are the bypass of pediatric neurosurgery. So at least we have a theme going today. So
They sure are harder to take care of.
exactly.
Medication.
No, look at this. It's magic. So it's just.
Like for you.
Oh, this is my medicine. This is what I look forward to. So I'm sure you're all very happy that I'm on the call schedule now because, one day when one of these patients shows up and you need help, I'm happy to help. But there's actually a story behind why healthcare advocacy is something that I'm very passionate about. And it's a story from fellowship. In DC, we had an unrestricted license, so we had to take attending call as the fellow. And one night I was on call. Our PAs took 24-hour in-house call just like our residents did. They were in the regular call pool. So I got a call at 2 a.m. because that's, obviously, all shunts fail overnight. And the PA said, I have this gentleman here who is a patient of Dr. Keating's. He's 29, has a shunt, was a myelomeningocele repaired at birth, and Chiari-2 malformation, had, 500 prior shunt revisions. I already tapped his shunt. No proximal flow. His vents are huge. He needs to go to the OR. And I was like, awesome, so I got up, it's 2 a.m. I was always taught never let the sun set on a shunt malfunction. So I was like, we're going to do it now, put on my compression socks because I'm going in for a bypass, so got to the hospital and the PA said to me, by the way, just so you know, this patient is on aspirin and Plavix. He has a history of a stroke. And I was like, okay, great. Not ideal, but no problem. So I went to talk to the patient. I was like, we'll run some platelets in the OR. This is a proximal revision. So there's a little chance of blood loss, things like that. And the patient looked at me and was like, actually, no, you're not, because I'm a Jehovah's Witness. And I was like, okay, curveball. Wasn't expecting that, and obviously made for a very complicated situation. So I talked to him for a while. He actually brought all of his paperwork with him saying that he would absolutely not take blood products, and he was awake enough that he could make his own decision. His family, he had a sister who was with him and had healthcare power of attorney in the event that he couldn't make the decision. And he was very clear he didn't want them. So we had a long talk. I talked to him about DDAVP, which I was trained during residency to give that sometimes as well. And so he agreed that he would get that. So we're ready to roll back to the OR. And the anesthesiologist comes up to me and says, we're not doing this case. This guy is 29 years old. This is a pediatric hospital. And we have a Jehovah's Witness program here that says that parents cannot refuse blood transfusions on behalf of their kids. And so we have to respect that policy. So I'm not doing the case. So here I am at 2 a.m, ready to do this. And now I met another roadblock. And so the gentleman says to me, well, this is really frustrating because I actually went to an adult hospital first and got transferred here. And at the adult hospital, there was a neurosurgeon there on call who said that he didn't feel comfortable taking care of a shunt, and that I was known to Children's National, which is why I got transferred here. So I ended up having to call a lot of hospitals in the DC area, and I found a vascular neurosurgeon who was on call at Washington Hospital Center named Jeff Mai, who was wonderful and accepted the patient. And I literally wheeled this guy across the street to Washington Hospital Center, where he ended up getting his shunt revised. So after that, I was really upset with how that whole situation was managed. And, I finally saw firsthand the fragmented care that these patients end up getting. And in someone in his situation who didn't have a very clear transition policy, and, Dr. Keating's last meeting with him in clinic had been follow up with an adult neurosurgeon when you're ready. And of course, he had never been established. So he was sort of floating out in the open when his shunt went into failure, and then ended up in this mess. So that's why I ended up getting interested in this. And I hope at the end you can see why this is something that we really need to focus on in healthcare in general. So healthcare transition in and of itself is certainly not a new topic. The transition from pediatric to adult focused healthcare for adolescents with chronic conditions is actually a growing phenomenon. It's estimated that about 10 million youth aged 0 to 17 in the United States have special healthcare needs, and this proportion of children with special needs is actually increasing with age. About 10% of children under the age of 6 have special healthcare needs, but this proportion almost doubles to about 20% for those who are aged 12 to 17. And today, 90% of kids with chronic conditions will actually survive into adulthood. And in the US alone, about 750,000 youth with special healthcare needs will reach the age of 18 each year. So this large number is a result of advances in treatments, obviously, pharmacology, surgical techniques, medical technology, and healthcare delivery systems that have been made over the last 3 decades. But unfortunately, upon reaching adulthood, many of these patients do not receive age-appropriate care. And as a result of this, there are actually entire departments, like the one I have pictured here from Texas Children's, and evidence-based tools that were created to try to tackle this exact issue. So healthcare transition emphasizes an intentional and planned process to move patients with chronic conditions from a pediatric model of care to an adult-centered model of care. And a systematic review has actually shown that structured transition processes improve population health, including adherence to medication and their quality of life. It improves their experience of care, and it also improves healthcare utilization, which means that there's going to be decreased ER visits and hospitalizations. And in addition to preparing young adults and their families for the transition to adult care, a critical component of a successful transition is the assurance of equivalent care in the adult world. And this is especially important for children who have medically complex diagnoses. So construction of a safe and mutually agreeable transition from a pediatric provider to an adult provider is one of the most challenging aspects of healthcare transition in neurosurgery. So there's clear evidence of need. A 2017 national survey of children's health showed that only 18.9% of youth with special needs receive the services necessary to make the transition into adult care. And Florida's doing great. We're well below the national average. We only have about 6.4% of youth with special needs receiving necessary services as they age out. So in the United States, the beginning of pediatric neurosurgery as a distinct specialty dates back to the founding of the section, which was part of the AANS in 1972. And this organization is now a function of both the AANS and the CNS, and it is called the Joint Section for those of you who aren't familiar. At the time of its establishment, a distinct and identifiable neurosurgical service existed in very few places, and fellowships in the field were actually only offered at 2 locations in North America, the first being Hospital for Sick Children in Toronto and Children's Memorial in Chicago. And so in the early 1970s, interest in pediatric neurosurgery increased primarily due to the development of the valve-regulated shunt. You knew I was going to talk about shunts for the treatment of hydrocephalus. So suddenly a large number of infants were given the hope of survival where none had existed before. So successful shunting also led to a renewed interest in management of complex medical diagnoses like spina bifida and the development of multidisciplinary clinics in order to manage these patients. So neurosurgeons were suddenly facing very unexpected challenges like repeated shunt infections and shunt malfunctions, which were challenging not only to diagnose, but also to treat. And so the chance to share those experiences, and Misery Loves Company, led to the establishment of the Joint Section in North America and the International Society for Pediatric Neurosurgery, which is also called ISPN. So it became obvious very early on that the spectrum of neurosurgical disease differed very greatly between children and adults. And a lot of work of a pediatric neurosurgeon is related to hydrocephalus in some way. So hydro that begins in infancy is significantly different than hydrocephalus that is beginning in adulthood. And much like many other chronic conditions of childhood, it is a diagnosis which requires lifelong follow-up. So the exact number of individuals with hydrocephalus in the US is unknown, but the diagnosis is associated with close to 70,000 hospital discharges in the US annually, and half of those involve children. In the early 2000s, US children with hydrocephalus were responsible for 3.1% of all pediatric hospital charges, which ended up being close to $2 billion of healthcare spending. And that number is only projected to increase. A 2009 study out of Utah predicted that the number of young adults between the ages of 18 to 35 who will need continued treatment for hydrocephalus will exceed 40,000 annually within the next 2 decades. And this article also sheds light on the fragmented care which is often given to these patients as they transition out of pediatric-centered healthcare into the adult world. The closing of a single pediatric multidisciplinary clinic results in 1/2 to 2/3 of those patients being lost to follow-up across all involved specialties. So transition of adolescents with hydrocephalus is often fragmented and disjointed, as I mentioned, given the relative lack of attention and research in establishing appropriate guidelines and also models for this condition. And this is a problem, not only due to the prevalence of hydrocephalus among the pediatric population, but also because of the significant increase in morbidity and mortality that's associated with poorly handled transfers and potentially life-threatening consequences of shunt malfunction. So to develop guidelines for a formal transition model for patients with hydrocephalus, it requires the input of all stakeholders involved, including patients, parents, caregivers, healthcare professionals. And as we stand currently, there is a near universal dissatisfaction with the transitioning process among neurosurgeons in pediatric centers and a general desire to develop best practice models. But given the lack of a systematic approach to hydrocephalus transition, the state of existing care has been termed the ad hoc approach or the as needed approach. So individuals and their parents have publicly shared troubling accounts why this approach doesn't work, like a 19-year-old female with shunt failure who was admitted to a psychiatric facility because of altered mental status. Or a recent story of a mother of a 29-year-old male with recurrent shunt infection who was recently prosecuted for Munchausen syndrome by proxy because she was trying to advocate for her son. So disease management is associated with substantial cost, and in pediatric neurosurgery, the number of patient encounters per surgical procedure is likely to be twice that of an adult neurosurgeon. The reimbursement system, especially in a subspecialty like neurosurgery with high malpractice rates and other overhead costs, is geared toward the surgical procedure. Less credit and compensation are given for management portion of the process, and reimbursements for pediatric neurosurgery are lower than for general neurosurgery. So fewer than 1 in 4 pediatric neurosurgeons are actually in a situation where all income is driven from patient billing. And despite the recognized importance of hydrocephalus and healthcare transition among the pediatric population, compensation for this time-consuming process remains unclear, despite the fact that it's been recently acknowledged in the 10th edition of the International Classification of Diseases. And by extending patient coverage under parental insurance through 26 years of age under the Affordable Care Act, this was an attempt to ease these concerns, but further work is obviously still needed to ensure that preventative care rendered by specialists is appropriately compensated for. So appropriate healthcare transition for pediatric patients with chronic conditions is a process that's strongly endorsed by the American Academy of Pediatrics, the American College of Physicians, and the American Academy of Family Physicians. And if properly done, this transition involves a multidisciplinary, holistic approach that attends to the biopsychosocial needs of the patient with the goal of maximizing their everyday function as part of their continuity of care. The U.S. Department of Health and Human Services launched a national campaign known as Healthy People 2020, which was followed by a push from the Federal Maternal and Child Health Bureau, in which they identified healthcare transition as a top healthcare priority. And so these platforms gained the attention of the Hydrocephalus Association, which is the largest patient advocacy organization in the US for patients with hydrocephalus. And hearing the concerns of its constituency, the association held a transition summit in Seattle to raise a call for action by key stakeholders regarding the need for healthcare transition and longitudinal care for patients with hydrocephalus. And during the summit, the group established a set of actions and measurable goals to be reached within the next 5 to 10 years in order to foster effective transition for hydrocephalus youth throughout the US and through Canada. So to identify topics for the summit, they had a cohort of patients and parents who were recruited to participate in separate focus groups at the association's national conference, which was held prior to the summit. And based on the focus group discussions, there were 6 themes regarding hydrocephalus healthcare transition that were identified. So almost all of the patients that were selected for the cohort admitted that they did not have a planned healthcare transition process, and many felt that they were left on their own to figure one out. Some of the young adult patients who had not had shunt problems since early in their childhood were never even advised to follow up with an adult neurosurgeon, and many were aware that they actually could be at risk of repeat shunt infections later in life. Many said that their local adult neurosurgeon were unwilling to see them. One parent was given a list of adult providers in the area, none of who would accept her daughter as a patient. Another family described their first encounter with an adult neurosurgeon who was overheard saying, quote, "She's not my science experiment," before walking into her exam room. And even when patients were able to establish care with a surgeon, they were often told that regular follow-up was no longer needed, and if they had problems, they should just go to the emergency room. So from the perspective of the adult providers, patients and families often felt that their new relationships were hindered by the fact that adult neurosurgeons received inadequate information from the pediatric provider. And as a result, their new neurosurgeons did not always understand the patient's condition and the patient's healthcare needs. Obviously, one of the biggest obstacles patients described were their immense anxiety about leaving their pediatric neurosurgeons. And although it's an oversimplification, many felt that pediatric neurosurgeons managed their entire disease while their new providers were focused on performing procedures. Pediatric neurosurgeons often care for adolescents whom they originally met on the patient's first day of life. Both the parents of these children, as well as their pediatricians, develop deep personal relationships with the neurosurgeon, leaving them feeling isolated and alone when they are transitioned out of their care. Participants reported that they received little guidance on what to expect or how to manage appointments, including medication and self-care. Managing and coordination of their own care can be difficult, especially for young adults with developmental disabilities who may require more support and direction than is usually provided for adult patients. And others noted the challenge that specialist care in adult medicine is commonly done in separate visits. This is in contrast to the multidisciplinary teams that are common in pediatric healthcare systems. So the economic challenge of providing integrated healthcare for adults with chronic conditions is daunting, and I completely understand that. Finding and maintaining adequate health insurance is a tremendous obstacle, especially since many pediatric patients are eligible for support by state and federal agencies through Medicaid. Obtaining private health insurance is a challenge, and even if they do qualify for Medicaid, the program itself has an uncertain future and is complicated by poor provider reimbursement, which results in a limited number of participating providers. And for those who are lucky enough to obtain private coverage, most felt restricted by their plan, especially when adult neurosurgeons in their area did not accept their insurance. So the consensus from the summit defined these 6 barriers as occurring at 3 levels: the patient and family psychosocial barriers, the barriers in training and availability of key healthcare professionals, and then healthcare system barriers. So from a patient and family perspective, recent trends have actually extended the pre-adult phase, which was previously 18 to 21 years old, to now include 18 to 29 years old. This creates an obstacle within the infrastructure of most pediatric practices, as 89% of pediatric hospitals will usually accept patients over the age of 18, but only 44% accept patients over the age of 21. And of that 44%, less than half would encourage the admission of patients over the age of 21. Parents who hover and are overprotective of their young adult inhibit their child's ability to develop independence in managing their own healthcare. And social disparities can undermine the development of self-management skills or access to appropriate care. And as patients age and establish careers of their own, they find it difficult to navigate taking time off of work for appointments or accessing public transportation to attend their follow-ups.
The same is also true, right? Like, you can't bring a pediatric patient, like anyone under 16.
To you guys.
And there are some times it's a situation when it is appropriate, but you run into the exact same roadblocks.
Yep. So all adult patients with hydrocephalus need a neurosurgeon, and I'm sorry to tell you guys that. But however, most adult practices are not designed to provide longitudinal care that many of these patients need. This means that the willingness of an adult neurosurgeon to care for these patients is necessary, but not sufficient to provide the required care. So pediatric neurosurgeons are obviously comfortable with the care of pediatric hydrocephalus, but very few of us are formally trained on how to appropriately transition patients out of our care. The ISPN described that many adult neurosurgeons will cite a self-professed incompetence to manage adults with complex hydrocephalus, despite the fact that shunt surgery is a core competency in ACGME curriculum. This suggests that a culture exists among trainees and participating neurosurgeons who allow the subconscious ignorance towards complex hydrocephalus patients. The Child Neurology Foundation and the American Academy of Neurology have both highlighted the role of child neurologists in planning and coordinating transition of children with healthcare needs. Yet neurology residents receive very scant formal education on hydrocephalus, nor is it considered a core competency of their training. Yet neurologists have the potential to play a very important role in the care of these children, as they could certainly offload some of the neurosurgery burden in terms of differential diagnoses and management of patient concerns. Physiatrists and pediatricians, of course, have essential roles in the care of these patients, especially in the setting of cerebral palsy or spina bifida. They can both make significant contributions to the longitudinal care of these patients, especially if they can continue caring for patients into adulthood. And keeping a familiar face in a patient's care team could certainly help to alleviate some of their anxiety about transitioning to an adult care team. As it stands today, there are 2 prevailing methods of healthcare transition in pediatric neurosurgery. The first is for patients to remain with their pediatric neurosurgeon after they become adults, but this only works where pediatric neurosurgeons have privileges in an adult hospital or where pediatric hospitals allow the admission of adult patients. The second is for patients to transition to programs specifically designed for adults with hydrocephalus, but based off of discussions at the summit, there are no more than 5 to 10 of these programs in the US and Canada currently. And clearly, neither of these models is a great solution. I've already talked about the undercompensation which exists for surgical and non-surgical care of both children and adults with hydrocephalus, which has been cited as a disincentive for continuing caring for these complex patients. And ongoing healthcare reform continues to threaten coverage for these patients with chronic conditions. As I mentioned, children who were previously covered by Medicaid or through CHIP may lose coverage at the age of 19, and 1/3 of young adults will lose Medicaid coverage because they fail to meet requirements for Social Security as an adult. So although healthcare transition is often thought of as the handoff of a patient from a pediatric to an adult provider, it's actually the handoff is actually done in the later of 3 series in a process. So transition preparation is the first part, which should start at a much younger age than adulthood. Transfer of care, which is usually around the age of 18 to 26 years old. And finally, integration into adult care. In 2011, the National Center for Healthcare Transition Improvement published a joint policy by the American Academy of Peds, the American Academy of Family Physicians, and American College of Physicians. It was published in an algorithmic structure with branching for youth with special needs and can be applied to both primary and specialty practices. The policy targets all youth beginning at the age of 12 and extends through transfer of care to adult practices around the age of 20. The 6 core elements of healthcare transition was rolled out by the National Alliance to Advance Adolescent Health in Washington, D.C. in 2014 and was reaffirmed by all 3 academies in 2018. In 2020, the 6 core elements were updated on the basis of experiences of multi-site QI projects, a literature review, and input from pediatric and adult clinicians, as well as youth, young adult, and family transition experts. So the algorithm begins with the introduction of transition policies when the patients are 12 to 14 years old. Their progress is tracked through their teenage years, and assessment of their skills are readdressed routinely. Planning for transition begins around age 14 to 18 years of age, at which time a formal plan is developed and self-care skills are built in anticipation of legally becoming an adult at age 18, unless, of course, there are alternative decision-making supports in place. The algorithm recommends the identification of an adult clinician during this time period and encourages communication between the pediatric and adult clinicians with timely exchange of current medical information. And then the final phase of the transition allows for reciprocal feedback between the patient, the family, and both the pediatric and adult provider. So the 6 core elements is not a model of care, but a structured process that can be customized for use in a busy practice and applied to many different types of specialties. The intensity of the transition intervention can be guided by several aspects, such as the complexity of the health condition, the social determinants of health, and adverse childhood experiences by the child and young adult. For example, if a young adult has a known problem with follow-up or poor adherence, they obviously will need more support during their transition period. The 6 core elements have been independently validated to facilitate an effective handoff in literature published by subspecialty practices, a managed care team, pediatric hospitals, and a pediatric residency program. So for each of the 6 core elements, sample tools are available, which can be customized for individual practices. For each core element, an implementation guide is available to assist in establishing a structured transition approach in any practice or healthcare system. It offers quality improvement guidance on what information and processes should be considered when undertaking each of the core element, with examples from different care settings and patient populations. Example documents are provided, which can be used as a guide to formulate handoff checklists, as well as transfer letters, which can be filled out by the pediatric practice once the final stages of transition are reached in preparation for integration into the adult care. There are also a lot of tools available which encourage young adults to take control of their own medical care, which can ease the burden of the eventual handoff. And activities like these can help to build health literacy, independent self-care skills, and assist in preparing for transitioning that happens at age 18. This is also a great time to aid them in the selection of a new adult clinician, taking cultural and social preferences into account, and most importantly, addressing the legal issues of supported decision-making should this be part of the planning if needed. So shortly after the release of the 6 core elements, the American Society of Pediatric Neurosurgeons identified healthcare transition as the highest priority topic for its advocacy efforts. In 2018, a survey of the current 178 active members who were certified by the ABPNS was conducted to analyze the current status of healthcare transition implementation at pediatric neurosurgical programs across the U.S. Survey questions were based on the 6 core elements of health that we already talked about in order to determine the extent to which each individual provider adheres to the GOT transition program. Answers to these questions were answered on a degree of preparation scale, with 1 representing the least degree of preparation, whereas a score of 4 represented a well-developed transition process. And as you can see, we did not do very well. Transition practices of ASPN members were poor in all 6 of the 6 core elements. Average responses were less than 2 on the 4-point scale for fewer than 10%, scoring 3 or higher in 5 of the 6 survey questions. So these results illuminate the current state of healthcare transition among pediatric neurosurgeons in North America. The overwhelming majority reported transition practices that are poor, do not meet the needs of patients and families, and should be improved. There are both ethical and economic arguments for addressing this healthcare gap, and it extends well beyond hydrocephalus. A study out of France reported on a small cohort of adult patients who had childhood brain tumors, hydrocephalus, or spinal dysraphism with regard to mortality, employment, and social outcomes. The authors found nearly ubiquitous continued medical complexity and high rates of delayed complications from their primary illness well into adulthood. In a recent cost-benefit analysis of a transitional care program in neurosurgery, the authors demonstrated a 16.3% reduction in length of stay and a 3.1% decrease in readmission rate for enrolled patients. But as you can see from these real patient testimonies, we still have a lot of work to do. So based on results of the survey, literature review, and critical review by ASPN leadership, the following best practice recommendations were released. As you can see, these essentially parallel the 6 core elements of transition that we already discussed. A written transition policy is the cornerstone of any transition process, and there are key elements to an effective one. A clear delineation of the age at which the policy begins. It should include information about legal medical decision-making so that children with limited intellectual capacity have appropriate documentation and legal filings that are completed long before the time they turn 18. And it should be accessible at an appropriate reading level, including translations into languages that are common to a practice. The policy should be introduced early and revisited often to foster a collaborative effort with the help of the patient and the family feeling empowered to participate in the process. The most challenging aspect of this entire transition is identifying an adult provider who is willing and able to accept patients in transition. The adult care provider should be identified early, and an initial meeting should be organized prior to the final handoff to allow for feedback to optimize and improve the transition process. So as I already mentioned to you, I can't give you the answer for how to fix this problem, but I hope I provided you with some tools. And the state of Florida actually has a program known as Florida HATS, which is Health and Transition Services, which is a product of Florida's Department of Health designed to assist professionals of all levels in navigating through the transition process. There are a lot of great resources, including diagnosis-specific checklists and care plans, as well as information guides for patients and for families. One of the biggest problems that we need to focus on as pediatric neurosurgeons is empowering our patients to develop independence and self-care skills, which will set them up for success when they finally do reach the age for an adult provider. Enabling them to feel like an adult will inevitably alleviate some of their anxiety when they actually do transition to adult care. But in my opinion, I think education is by far the most important tool that will allow us to bridge this gap. Both medicine and surgical providers need to work together at local and national levels to improve the care of the patients that we serve. We need to emphasize the importance of healthcare transition at all levels of education, including our APPs, nurses, social workers, and navigators. And above all, a structured approach built from a foundational partnership between pediatric and adult neurosurgery is paramount for the widespread adoption of these programs. So we literally need to start at the bottom. That goes for you guys, the young and happy residents who have an incredible opportunity ahead of you to be part of a bigger movement. Data from focus groups demonstrate that although training in chronic disease is important to providers, it's not adequately addressed during residency. Recent graduates of residency programs across multiple specialties cite gaps in training regarding chronic disease management. A large percentage of programs do not provide any education on the transition of pediatric to adult care. And even before that, medical students should be taught about care handoffs, disease management, and other points around transitioning into adulthood. These values will hopefully one day be incorporated into the content and testing for the USMLE. Teaching this content to medical students while they're still undifferentiated will help them prepare to care for youth with special healthcare needs regardless of their future field. And clearly, we have our work cut out for us. So I'm going to end with this. It's a quote from a very reputable source known as Gomer Blog. Of the existing shunts, only a number are allowed to be working at any given time. When a neurosurgeon revises a broken shunt, somewhere in the universe, another shunt breaks. So as you can see, I have given you something from this talk, and that's job security. I hope you learned something. I hope you can leave here today with a new appreciation for our graduating patients. But most of all, I really hope you all learn to love shunts as much as I do, but that is a lecture for another day. So.
Excellent, very well delivered. And
Thank you.
Very warm.
Thank you.
I also want to tell you that I'm very happy. I was very happy to hear your talk because, now I have just a Monday mornings a follow-up clinic where I mostly see follow-up patients, and most of the patients that I've operated through the year, vascular patients, are either well or dead. So they don't come back to the office. But I do have a group of patients with normal pressure hydrocephalus and a failed shunt who do keep coming back to the office. And I'm delighted to hear now that you're willing to see these
Happy.
patients. The average age is about 70, but it's still a childhood disease,
Of
right?
course.
So if you're willing to take those patients in your office, I'll be happy to
I would
transfer.
love to. I can imagine Nicholas will be so thrilled if I bring them over.
So I mean, that's, you concluded that there is gonna be someone in the adult world who does take care of patients. Is that the conclusion?
My goal is that at some point we can do better in peds to have a program in place that will set people up for success so that the transition isn't as daunting as it is right now. Because I think the problem is, I mean, I will be honest with you, I trained at a place at AGH. We had an adult hydrocephalus center, which is incredible. We had an attending that was an adult neurosurgeon who only took care of hydrocephalus patients. And so I saw it from the other side with how easy and smooth that transition was, because, she would get these absolute binders of healthcare history from these patients, but she was interested and took the time to go through all that. And I appreciate that that's not possible for a lot of people, especially in the adult world. But what I hope is that we can do better preparing our patients for that transition. And yes, part of that is finding someone who's willing to accept them. But I think if we're better about getting them prepared for the transition, helping them sort of have a concise handoff that doesn't make it so complicated, that ultimately, I think a lot of them just want to be heard. I think a lot of them would just appreciate having someone that they have as a point person that they can go see, even if it's once a year, just to say, I'm doing great, or they're saying, I'm not doing great. And I understand that that's a big ask, because adult neurosurgery is certainly not the same in terms of the time that's spent in clinic managing these details. But I think it starts with us personally. I don't think that the adult aspect of this is really the most important thing right now. Of course, we do need adult neurosurgeons to take them.
I was gonna ask you, is there a model out there, and I don't know of any, but I'm just curious, is there a model out there where a pediatric neurosurgeon does take care of these patients
Yeah,
as an adult?
the problem is those are places where they're usually hybrid jobs, where they have a pediatric practice at the same time that they have an adult practice. So a lot of these places, like, not here, but at places where the children's hospital is within an adult hospital, they have the opportunity to have pediatric and adult patients. And a lot of those neurosurgeons take pediatric and adult calls. So they have a very well-established practice of all ages. Those are the only people that are really set up for that to be a successful
Any
transition.
examples of uber successful programs like that?
There's a gentleman I know in Indiana who works at, I think, Beacon Health System, Dan Fulkerson, who is a pediatric neurosurgeon, but also takes adult call. And actually, he gave a talk at a conference I was just at not too long ago about how this is a real problem, but he's in a situation where it's not really impacting him because he has the ability to do that transition himself. But a majority of us in the US don't have that option. So we're working on it. And I think that's something that I hope to focus on, and I hope that, we're working on as far as the organizations are coming up with a plan that we can have a model in place to make this easier for you guys too, the accepting physicians, because your job is just as important as ours.
Christian, that was a great talk.
Thank you.
And I, a couple of points. One, of course, is I didn't know there was an ICD-10 code for transition of care, but unless there's some commensurate RVU value attached to a CPT code, it's not going to attract anybody's attention. So it's great that there's a diagnosis code, but I think advocacy has to include some sort of meaningful reimbursement for it. And, we pawns in pediatric neurosurgery don't have a seat at the table that assigns RVU values to CPT codes. That's in the adult world, and most of those guys are spine doctors, by the way.
No, it's actually, no, it represents all of us. That's not true.
It does, but there's
There's no interest in it.
Yeah.
there's no pediatric person who does it.
Essentially runs the CPT route. It's very complicated, despite people have a stronger interest in it.
Indeed.
And we spend, it's a labor of love, but I think they would welcome anybody in the peds world to come spend the volunteer hours of hundreds of hours a year to do it. And I'm
It-
that
me-
offer out.
yeah.
As a-
Maybe we can find a young volunteer who would be interested. I think I see one with us.
Wonderful to have that.
It would be great because that's one of the chronic issues for us in pediatrics is we've never felt like we had a seat at the table in the development of that system. And whether it's been opportunity or understanding of the system, it's been absent. And then the other thing is Dr. Levy's question about systems. So there's three ways to do this, right? Find somebody outside of neurosurgery to do it, outside of pediatric or an adult neurosurgery system. And University of Washington has a neurologist who runs their hydrocephalus program, very successful. So they transition their
Mhm.
patients to the adult neurology practitioner who takes care of them all. And it's Rich Ellenbogen, so everything's wonderful. You never
Yeah.
know. The other alternative is to have a pediatric person who has a hybrid practice. And the credentialing body for pediatric neurosurgery lowered the number of pediatric cases necessary to maintain your special, whatever we call it now, certification as a pediatric neurosurgeon. And there is no upper limit of the number of adult patients you
Mhm.
can take care of. So they used to be punished for taking care of adult patients, and that's gone away. So from the pediatric side, we've done what needs to be done to have somebody who has a hybrid practice that takes care of adults and children. And then the alternative is to convince people who go into general neurosurgery that hydrocephalus isn't evil, and that if you do it right, patients just come back and say hello once a year
Yeah.
and thank you
Yeah.
for their longevity. So I think there's three ways to do it, but we need a plan, and
Yeah.
we can't just do it. We can't do it by ourselves, right? We need somebody on the adult side to help us.
Yeah.
And I'm talking to the rest of the room. Thanks for bringing it up.
Thanks, everybody. The residents are all terrified now. I know, like, don't look at me.
So thanks for the opportunity. It's an honor to be here. I've been here for 3 months and really excited to be at the University of Miami. So I'm going to talk about basilar brainstem bypass and hope to convince you that they have something in common. So no disclosures. Important to acknowledge people that I'm very grateful to and for. A lot of what I'm going to show you here, I've learned a lot of tricks from Dr. Spetzler, Dr. Lawton, and applied some of those in my practice, obviously, but also owe a lot to the chairman that have given me opportunities, including Dr. Levy. So thank you to all these folks. It really takes a village and a team to take care of these patients. So when we talk about tertiary centers, quaternary centers, we're not talking about the surgeons, we're talking about the ICU nurses, the OR, the equipment, the capabilities, the monitoring folks, neuromonitoring, everybody involved that takes care of patients. So this talk is going to be mostly about open vascular neurosurgery, but I do a lot of endovascular neurosurgery. I love doing endovascular neurosurgery. In this day and age, there is no open treatment for a CC fistula that makes any sense, and I don't think there will be. So you have to know endovascular neurosurgery. You have to love it, and I think that you have to offer it to the patient because you're gonna lose that patient if there's no open approach. And most of this is going towards endovascular, but I hope to convince you that there are still some things that need open neurosurgery. I know you know that's true, it's rhetorical. So in any case, hybrid and open endovascular and endovascular surgery, when you come to work, you're wearing a different hat one day versus the other, or you're doing both cases on the same day. And you really have to believe in what you're doing that day when you do open neurosurgery or endovascular neurosurgery. Now, after the BRAT, the barrel ruptured aneurysm trial, some of the quotes from Locke McDonald we'll look at here. Advocates of neurosurgical clipping are fighting an uphill battle with fewer and fewer troops. That's really the backdrop of what I want to talk about with you all today. For the residents, which one of you is going to be a brainstem surgeon, a bypass surgeon, a basilar surgeon? Can we inspire you, motivate you to consider these pathologies? Because a lot of these skills are going away, and for good reason. The numbers are just not there anymore in a lot of places and in a lot of training programs. And so There are places where there is not a definitive open option. We had a mycotic aneurysm last week, and it required a very complicated bypass. We went to common first, then to STA, used a saphenous, went to the distal M3 and cut out the aneurysm. There was no endovascular approach for that, and there was no open approach that didn't involve a bypass. And these cases are really being concentrated nowadays. And what they suggested in this editorial in England is, instead of taking call for your hospital, should you be taking call for a region when you're the open vascular neurosurgeon on call? And in some ways that makes sense, and I'll show you why. So when we think about choosing an approach to a vascular pathology, whether open or endo, we really just want to minimize complications. That's what I want to do. Sometimes the choice is easy, sometimes it's not. So these are the metrics or the rubric that I go through in terms of how I choose. The anatomy is obviously the most important, but then we start thinking about patient age, laterality, speech dominance, and these are two very different ways of treating aneurysms or vascular disorders. And here are some of the comparisons, right? Open is much more invasive. There's no craniotomy for an endovascular procedure. You can go radial, it's less invasive. Sometimes the cases are shorter. The durability is obviously better on the open side, and that's been shown time and time again. Length of stays are similar unless you have a subarachnoid patient, and then they're the same. When you're doing an open case, you really have good tactile and haptic feedback of the aneurysm. You're touching it, you're using instruments, versus when you're using a catheter or wires or endovascular techniques, it's a little different. It's a push and pull, but not the same haptic feedback that you might get in the OR. Visualization obviously is different, color versus black and white. The response to bleeding, when you see bleeding in the OR, obviously when we're surgeons, when we see bleeding, it's stressful. When you see bleeding on the screen, it's just as stressful, but it feels different. But your control is improved, right? You have a suction in your hand when you're in the OR. But when you're in the angio suite, you don't. Your choice is to coil the aneurysm quickly and stop the bleeding, maybe put up a balloon, reverse the heparin. So things are obviously different, but a patient can have a fatal complication regardless of what you're doing. So just remember that. Now, basilar brainstem bypass. Do these things have anything in common? I know you all think that I just woke up and picked the pathologies that start with B and put them in this talk, but hopefully we can convince you by the end that maybe that's not the case. And these are cases I enjoy managing. I talked to Rick Komatar the other day. He says, when you call a referring doctor, tell him you want the redo basilar tip or fusiform basilar aneurysm. And maybe there's some pathology in wanting those cases myself, but these are the things I enjoy. These are the things I want to do. These are the things I want people to send us here at the University of Miami, because we have a responsibility at University of Miami in Jackson to take care of these patients, because most people don't want to, believe it or not. Most people in Florida do not want to touch the basilar artery, the brainstem, or do a bypass these days. That's just the time that we're working in. And when we talk about complexity, a patient will ask, what's the complexity of this operation, 1 to 10? These are 9s and 10s. And it's not just the complexity of the operation, right? It's the amount of emotional, mental fortitude it requires to get through these cases, physical fortitude. These cases, in my mind, require stamina. My first month, I'm not proud of it, but one of these cases took me 24 hours, vert to radial to pica bypass, far lateral, to cut out a proximal pica aneurysm. And so these cases will test your stamina, they will test your fortitude, but you do them over and over and over, and you become recalcitrant to that stress level. So they require a lot of preparation and forethought the day before. A lot of these cases will be sent to me, and you'll hear the word inoperable used, and I'll show you that there are ways to get into these places right there at the center of the brain. And it's like really unlocking a safe. If you have the right approach, the right tools, the keys, you can get in there. Now, these cases are being concentrated, as we said. There are over 150 neurosurgery residency programs. There are 10 fellowships, 10 in open vascular neurosurgery. So we want to see that regional centralization of these cases. We want to be on call for large swaths of the population, or large parts of the population. And the anatomy is really incredible. That's part of why I love these cases. I know the residents love seeing the anatomy of the skull base, the cranial nerves, and I'm excited about it. I like teaching about it. It's hard not to be passionate about this. When we have a case that's difficult, we go to the lab. The skull base lab is very important. We go to the lab, we try the approach, we test it, and vice versa. Sometimes we do an approach and you can't really see it that well under the microscope, but then we go back, we demonstrate it in the lab for publication purposes. Creativity. Now, Dr. Levy will tell you on an ACD, stay away from the vert, right? But for you residents out there that really want to go find it, we will give you a way to find it, go looking for it. If you stay with me till the end of this talk, I will show you an ACD when we were looking for the vert, found it and bypassed to it at C3. So again, I know you guys don't want to find it, but maybe you do. So we'll show you that case later. Publications. I mean, these are things that I like talking about, illustrating. We had a phenomenal illustrator, Ken Probst, who you guys know from the 7 series that I worked with, had the opportunity to do some artwork, and obviously his artwork is so good. He got us on the cover a few times. So these things, as you can tell, have things in common. A lot of these cases have exhausted conservative management or endovascular management. And again, because of the declining numbers, the declining number of programs that offer these, we're seeing fewer cases for the residents, for the fellows. And really the point of this is to hopefully get somebody in the audience from the trainees who want to do this so that we can pass on the torch, continue to educate the future. And so you residents, when you have residents, will teach them these skills as well. So that's the goal here. So we are pushing the envelope. We will push the envelope on the endovascular side. But this is a call to arms, as Dr. Lawton said in his vascular manifesto in 2013. There are cases that still require microsurgery. So what's the pathology? For basilar, it's aneurysms. For brainstem, it's malformations. For bypass, it could be hemorrhagic or aneurysmal disease or tumors. These are some of the publications that I talked about that have come out recently, but it's really more about the artwork, the illustrations. This is the approach to the middle cerebellar peduncle, again, illustrated by Ken Probst that made the cover. The Kawase approach, I do it intradurally. It's a lot like an intradural clinoidectomy. A lot of people will tell you to do the anterior petrosectomy extradurally, but I find it a lot easier to tailor it, to see what I'm doing by doing it intradurally. And that's what we're describing here in this approach, where we find the 4th nerve and then we open the dura lateral to the SPS and we join the supratentorial and infratentorial space with a cut through the SPS, and now you can work on both sides of the cisternal segment of the trigeminal nerve. So I'll show you some cases where that's helpful. Bypass surgery, how we do it. This is a illustration by Ken Probst that we put out in ACTA. The transquadrangular lobule approach. So we transgress the quadrangular lobule. This is a new approach to the brainstem that we described in the last 4 years in San Francisco. When we think about the pons, we often come through the middle cerebellar peduncle. But when the long axis of the lesion is from midbrain to pons and it's up and down, it's vertical, it's better to enter in the midbrain and head down. And the way we do that is infratentorial, infratrochlear, and that's what you can see here. This is a cab mal located at the pontomesencephalic junction. We're going to transgress part of the quadrangular lobule to give us a more inferior trajectory down rather than coming through the middle cerebellar peduncle. And I'll show you that approach. And then we talk about basilar aneurysms. No series should have just open cases. So this is my single surgeon series of both open and endovascular treatment of the same pathology, and we compared the results. And again, these are the covers that obviously a phenomenal illustrator like Ken Probst afforded us the opportunity to be on these 2 covers most recently. So basilar artery, we know that basilar aneurysms are challenging to treat, whether it's open or endovascular. So what we did is we went back and looked at my 5-year series early on in my practice of treating this pathology, 1 surgeon, but 2 different procedures. And so it was a 5-year study period, 42 patients. And the goal was, number 1, can or should this even be done anymore from the open side? Is this a lost art, or can we continue it? Can we do it safely? And number 2, how different are the outcomes between open and endo? So these are the approaches that we used. I either went OZ, subtemporal, transcallosal, or I did a stent coiling or primary coiling endovascularly. And you can see the illustrations. Here's a video that just shows you. Let's see if we can get that video to play. Well, that's all right. The video is not going to play, but in any case, here's another basilar tip aneurysm. And so where are we working? So we're working behind or deep to the internal carotid artery. You can see the 2nd nerve, the 3rd nerve here, internal carotid artery, the PCOM. And when we section the PCOM here, we do it close to the P1-2 junction where there are no perforators. And by doing that, we open the space so that we can go down and see the basilar artery. Now we're working between both third nerves. Here's the basilar tip aneurysm, the perforators. This aneurysm we treat by giving adenosine. We soften the aneurysm, and then I'm going to use a picket fence technique after I've cleared off all the perforators and clip that aneurysm just like this, preserving the ipsilateral P1. Here's the basilar artery, contralateral P1. And you can see the icy green, all the perforators are open. So that's our transsylvian approach to the basilar artery. What about the subtemporal approach? So what does that afford us? So when you do a subtemporal approach, you might get down to the level of 4. That's going to be your inferior limit. But by opening up the tentorium and working around 4, you can get to 5. But if you need more proximal control, then you got to drill Kawasi's quadrangle and get inferior or lateral to 5 so that you can get a clip on the basilar artery near the 6th nerve. So that's the approach. And Neil Martin describe this transtentorial approach, but look where it gets you. It gets you to Meckel's cave. And that may not be enough for your particular aneurysm if you have a low rising basilar tip and you need to get more proximal control. So what we do is we open this up first, working between 3 and 5. Then we're going to work more laterally to the SPS. And you can see this is Kawasi's quadrangle. Okay, so V3, GSPN, Petrus carotid lies just deep to V3. And we're going to open up over the infratentorial dura. So how do we do that? So this is the space where you're going to find that dura subtemporally, but we're not going to do it extradurally. We're going to do it intradurally. Now, the first few I did extradurally to find the landmarks, but I'll show you that you can find those landmarks intradurally. Here's the craniotomy, and that was an extradural drilling case where we can see 5. This is an AICA aneurysm. This is the 4th nerve here, basilar artery, and this was a partially thrombosed AICA aneurysm where we needed to work on both sides of 5 to get it clipped. And we published this technique recently in World Neurosurgery, and this is the illustration that I showed you. So how do we do this? First thing that we do is we open up posteriorly along the tentorium where the 4th nerve is free of the tentorial edge. Start to make a cut parallel to the 4th nerve so that we don't cut it. Once we do that, we start to open the dura up both ways. We get to the level of the SPS. We can't go any further inferior. Then we open up the dura over Kawasi's quadrangle. We drill it out till we see infratentorial dura. Then we communicate supratentorial with infratentorial space by bipolaring and cutting the SPS. Once we've done that, we're working on both sides of 5 as it goes into Meckel's cave. Then we can see AICA and 6th nerve and the basilar artery proximally. And here's a case where we did that. So we have an aneurysm on the 3rd angiogram, basilar perforator blister aneurysm that was not seen on the first 2 angiograms. Clear subarachnoid hemorrhage, clear aneurysm here on the 3D, and you can see it here on the CTA as well. And now we have about 7 of these basilar trunk perforator aneurysms. This one you can see here behind the sella, but proximal control for this type of aneurysm is much lower. So again, here it is, 4th nerve. We're going to section the tentorium here. And now we're going to see the 5th nerve. We're looking at the side of the midbrain, branches of the SCA. Here's going to be the dura that we open. This is going to be the SPS that's coming through here. We're going to open the dura and then drill this bone out here till we see dura of the infratentorial space. So we do that there, and then we communicate the dural opening. So now we're on both sides of 5. We can get proximal control of the basilar artery. And then when we see this aneurysm, there's the 6th nerve, there's the AICA, basilar trunk deep. Here's the 5th nerve coming up or forward as it goes into Meckel's cave. So once we've done that, now we can see here's the basilar perforator aneurysm, right? It's always partially thrombosed. There's always a little basilar perforator right there, and it's usually out. And you're not going to save that perforator because it's already gone, and the patient often has a stroke. Pre-op. But if you put a flow diverter down, what are you risking? Not just that perforator, but other perforators of the basilar trunk. So we don't necessarily want to do that. We're going to come in here, we're going to ligate this aneurysm, which is partially thrombosed, verify that this vessel is not filling, and then ligate this. And oftentimes the neck tears. And I think the residents saw a neck tear recently. What I do is when the neck tears, I put cotton and then I put the clip over the cotton against the neck to close the hole. Because if you keep trying to clip the neck tear with just aneurysm clips back to the vessel, eventually you're going to make the hole in the parent artery bigger and bigger, as you all know, and that's just going to cause a bigger problem that you can't repair. So there's the aneurysm here, clearly the source of bleeding in this patient. We clipped it, and this is like a DLIF, right? It's directly lateral. There's no inner body, but we're going directly lateral to the basilar artery, and just from the side. So, we got to make a little bit of an analogy. So in any case, you can see the mesh here directly behind the brainstem or the basilar artery, and there are the clips. So we got this perforated aneurysm. Here's another similar case. I don't think the videos, oh, it is going to work. There we go. So you can see that working beneath the fourth nerve here, we've got better control. We're working on both sides of 5 and taking the temporary clip off for a basilar tip that I did subtemporal about a year ago. So the half and half approach, I showed the residents this recently. It's really a subtemporal and a transsylvian. So when do you need that? When you're working between 3 and 5 and you're right on the cusp of the retrocellular space, but the aneurysm pooches out a little bit superior to the posterior clinoid. So here's 3, here's 4. And what we've done here is we've gone transsylvian, not just subtemporal, but we've opened up the tent so that we can also work on both sides of 4. We don't need a quasi approach here in most cases. This was a 50-year-old man, intact, negative angiogram. He has a perforator blister aneurysm on the back of the basilar apex. You can see the thrombus in it. We didn't find this on the first angiogram. Now we go in, we can see the perforators, and there's no endovascular option. You're not going to flow-divert across the basilar apex into the PCA. So there it is. There's the hole in the aneurysm. We've got adenosine, and we're going to clip all the way back to the basilar trunk to make sure that this aneurysm is treated. So there's the opening or the window in the tutorium. This is the third nerve. This is our half and half approach, half transsylvian centered around 3, half subtemporal centered around 4, and working right at the cusp. And just to show you the anatomy, this is the PCOM. This is actually the SCA, and this is the PCA coming up over the third nerve. And Dr. Day used to say when there's a low riding basilar tip, hopefully I don't get in trouble for this, he used to say touchdown Jesus, because you're putting your hands up and the P1 is going over the third nerve, has a very long course. And that's what you guys are going to see when there's a low riding basilar tip, is this P1 takes a very high course over the third nerve. It has to get there, so it's vertical in its initial segment. So there's that. So I'm going to move forward and basically show you the results. So in this series, there were no differences between open and endovascular in terms of the outcomes in a statistically significant way. There were some notable findings. You can see the modified Rankin analysis here for endovascular open and combined. There were 2 deaths, 1 in each series. But the notable findings were that patients were younger, as you would expect for the open cases. That's selection bias. 56 versus 66, that was significant. And then obviously their preoperative modified Rankin had some influence on their final outcome, which you would also expect. Again, 1 death in each group, so not significant, but not powered either. And aneurysm obliteration was higher in the open group, as you can imagine, and as was published in prior series, a lot of prior endovascular basilar tip series and open basilar tip series, but this series really looked at both. And modified Rankin, again, was similar between groups, slightly higher 0 to 2 in the endovascular group, as you would expect. So again, this series, 42 cases, it's not a huge series, but it was single surgeon, and it was my series where I looked at open and endovascular treatment and showed that you can do the open cases safely with comparable results to the endovascular treatments in 1 pair of hands. So choose carefully. Transventricular approaches. So one of those cases was the transventricular approach from top down. I'll show you another case. So this patient, young patient, 29 years old, with a thalamic AVM that ruptured. No, thalamic AVM, but a AVM nidus-associated aneurysm at the anterior aspect of the AVM, and it's located in the third ventricle. So to clip this aneurysm, the plan was to radiate the AVM. He has a thalamic AVM. We're not going to remove that, and it didn't bleed. So we're just going to clip this aneurysm. It was difficult to catheterize this, so it was sent from our endovascular colleagues, and this was a translamina terminalis approach. Right optic nerve, left optic nerve, lamina terminalis, ACOM here. So this aneurysm was pooching into the third ventricle, and you can see it here. So we worked on both sides of the ACOM and clipped this with 2 kissing clips here, mini clips. There's the ruptured aneurysm, and you can see the approach here through the lamina terminalis to clip this aneurysm-associated aneurysm, or AVM-associated aneurysm. Similarly, 51-year-old patient with a AVM-associated aneurysm in the third ventricle. This was unfortunately or fortunately happened to be my first case when I was on call and got referred to me. But anyways, went transventricular, opened up the foramen of Monroe, got down to the third ventricle, and we clipped this aneurysm and resected it and also the AVM, and she ended up doing well. Here's the third ventricle AVM associated aneurysm. Here's the perforator that it feeds off of, and you can see the thalamic AVM now in this location. So I'm going to move on to brainstem because I do want to leave a little time for questions at the end. Malformations. So we know that brainstem calf mals have an aggressive natural history, but we do wait because of the outcomes and the deficits that we might see with open surgery. So what do we wait for? Well, the guidelines say 2 bleeds, comes to the surface, patient symptomatic. And that's typically what we wait for when we're talking about taking out brainstem calf mals. I was fortunate to be able to write up this series for Dr. Spetzler on his series. It was the largest series at the time. And again, brainstem calf mals don't have an endovascular option. So we're talking only about open surgery here. And why should we intervene? Well, when the patient has a bleed from a brainstem calf mal, we see a decline and then a gradual slow recovery. But what I tell patients and what we see is that patients may not make it all the way back to their baseline. And every successive bleed is going to make them worse before they have a chance to get all the way better. So why do we even talk about this? Well, we know open surgery is going to give them a hit. And I tell patients after the open surgery, it's going to feel like you had a bleed. But if we don't operate, they're just going to slowly get worse and worse and worse. They're going to be hemiparetic, they're going to lose speech or swallowing, they're going to have a trach or a feeding tube. But when we operate, although it may mimic a bleed, we remove the cause of future hemorrhage and save them any further stepwise decline. And that's what we basically discussed when we were talking about this series. Now, the approaches to the brainstem are a lot like the approaches to the basilar artery. And so that's why there's a lot in common with these. We're going to use a lot of the same approaches. So what are the 4 main approaches we used? The suboccipital approach directly midline with C1 Lamy. Retrosig is the workhorse through the middle cerebellar peduncle. Lateral supracerebellar approach, which I showed you, going infratentorial, infratrochlear, and the far lateral for lesions of the medulla. The OZ approach is not as useful, neither is the Kawase, although we still need it from time to time. So what is this trans or TQL, transquadrangular lobule approach? Again, when the long axis of the lesion is vertical, we are going to, instead of going through the middle cerebellar peduncle behind the 5th nerve root entry zone, we're going to enter from above at the midbrain or midbrain pons junction and head down, and we're going to transgress anterior quadrangular lobule. So what is the anterior quadrangular lobule? I'll show you that here in just a moment. But this is really analogous to an approach that we reported when I was a fellow, and Dr. Lawton showed you all about a few weeks ago. When we're approaching the pons and the lesion is on the inferior aspect of the pons at the pontomedullary junction, what we want to do is we want to do something similar along the long axis of the lesion, come from inferior to superior. And how do we do that? We basically go through the pontomedullary sulcus just above the inferior olive and head up into the pons from the underbelly of the pons. And that gets you that superior trajectory into the pons through a far lateral for low pontine lesions. Well, the transquadrangular lobule approach is just the opposite. Instead of coming directly from the side through the middle cerebellar peduncle, imagine a lesion that's superior to inferiorly situated, right? If you come from the side, you're going to end up with a kind of a windshield wiper technique through the pons, looking up, looking down. You're not going to be working down the long barrel of the lesion. So what we do is we start at the top of the lesion and work our way down from the pontomesencephalic junction and work down. So how do we do that? So we make a supracerebellar craniotomy. This is how I position them. You can position them sitting, which also works very well, or supine. And you're working along the flatter aspect of the tentorium, not in the midline where you're going for the pineal or the tectum. So here's the quadrangular lobule. This is what we're going to transgress to get us a more inferior trajectory into the pons. We're going to go infratrochlear, and this is what that looks like. Once we've gone or transgressed this, we can head down into the pons. So what does that mean? Well, I'll show you some cases in some MRIs that show you where it's really well suited. But here's the entry zone where you're going to enter below 4 for the TQL approach. Compare that to the blue, which is the middle cerebellar peduncle approach from the side into the pons, behind the root entry zone of 5, where you've opened up the horizontal fissure. Now we went back to the lab and we looked at the cranial nerve nuclei and tracts that are in the vicinity, and we included this obviously to show what is at risk with this approach versus the middle cerebellar peduncle approach. Although they're very similar, what you minimize when the lesion comes to the surface of the pontomesencephalic junction posteriorly, you minimize the amount of transgression of the middle cerebellar peduncle when it really doesn't come that far lateral. And so here's a lesion, 19-year-old patient, clearly hemiparetic. He actually has two caved mouths, this very large one in the pulvinar and also this large one in the pons. And with this approach, actually, we could remove both through one incision and one craniotomy. Now how do we do that? So we're going to go supracerebellar, cut the tentorium, and then we're going to get into the thalamus from the thalamic mesencephalic junction from the back. The pulvinar is very well tolerated for pathology, as you know, and this was a lesion that we removed through a supracerebellar transtentorial approach. But that's not what we're describing. We're talking about the transquadrangular lobule approach, and you can see this lesion here comes, this is the top of the cerebellum, this is the lesion, comes to the back of the pontomesencephalic junction. So this approach is going to be over the cerebellum, entering back here at the back of the midbrain, infratrochlear, and then heading down. Why do we need to head down? Well, look how far inferior this extends. So by taking some quadrangular or transgressing some quadrangular lobule, we can get inferiorly and resect the whole lesion. So that's what we did. So this is the resection cavity after the thalamic cavernal is out. This is the resection cavity after the pontine cavernal is out. And you can see that we used one craniotomy. We went here, cut the tent to look up. We went this way, went transgressed quadrangular lobule to get down. Now, this patient had some worsened hemiparesis, but overall was a modified Rankin 4 pre-op. He stayed that way post-op. He was the patient who started out off the worst. Here are a few other illustrative cases where we use this transquadrangular lobular approach. Again, very similar ponto mesencephalic lesions that come to the back of the midbrain and are really better suited for a supracerebellar approach. Now, moving on, these are the outcomes from that series. It was 6 patients. We reported this in operative neurosurgery in 2021, and this is one of the ones where Ken Bropes made the cover. So this article is featured on operative neurosurgery. So this was well tolerated. There were no cases of ataxia related to superior cerebellar peduncle in this series. It does permit more superior to inferior trajectory, and it is analogous to the transpontomedullary sulcus approach through a far lateral, but the opposite. Now, looking at the horizontal fissure approach, when the lesion does come lateral to one side, and it is mostly in the pons, this is the workhorse, as Dr. Lawton showed you all, of brainstem cavernal surgery, is the transmiddle cerebellar peduncle approach. Now, how do we do that? So this was a 29-year-old patient, a firefighter, and he had this very large lesion, hemiparetic, and so, or 33. And in any case, is there any way to fast forward? Maybe not. All right, we're just going to skip that. But what I do want to show you is the illustration. So when we're doing a transmiddle cerebellar peduncle approach, we're opening up between the superior and inferior cerebellar semilunar lobule. We're opening up this petrosal fissure or horizontal fissure. And as we do that, we can get more and more and more posterior behind the root entry zone of 5 so that we can enter the lesion where it comes to the surface. Now, this is a left-sided approach, superior and inferior cerebellum. This is a 7A complex 5. So this is where we're entering behind 5 to get into the middle cerebellar peduncle. And what does that look like? Yeah, it's not going to work. So then another case, when we're talking about brainstem pathology. So this patient, 10 years old in northern Florida, they called me in San Francisco, said, this patient is going to get gamma knife. The parents are very worried. It's going to take 2 years to work. He's already had a hemorrhage. He's been in the ICU. It took 6 months in rehab to get him back to where he was. Parents are obviously, number one, they were devastated by the bleed, but he recovered. And number two, they're terrified of another one. So they don't want to wait 2 years. He was in the ICU. Finally got extubated after a month. And so they said, look, we don't want gamma knife. I said, all right, well, come to San Francisco. So we took out this AVM. You can see it involved the 7A complex, the 5th nerve root complex. This is the patient in the ICU post-op day 3 after his angio, doing well. He was, I believe, 10 or 11 at the time. This is back in Florida. And they did a nice news story and had a catchy title to it, 3,000 miles to a cure. just because he came from Florida to SF for surgery and ended up doing well. The family was gracious enough to be a part of this. And we did a similar story with a Virginia patient most recently. And this was kind of what we wanted in San Francisco. We wanted all these cases that were going to get gamma knifed elsewhere to come and have definitive surgery. We had a great pediatric neurosurgeon chief, Dr. Gupta, who Dr. Levy knows, who is phenomenal to work with. And that was kind of what we wanted. That was the brainstem part. We wanted these brainstem AVMs. So finally, when your lesion comes to the superior aspect of the midbrain and is at the floor of the third, don't forget that transchoroidal fissure approach we showed you earlier, where you can actually work through the floor of the third to get into the midbrain, because sometimes it doesn't present anterior or posterior to a peel surface, but superior. So another case of using that approach to get to the brainstem. All right, I do want to spend a lot of time on bypass because this is probably my favorite part of the talk. We know that open surgery is more invasive but more durable, right? There are pros and cons. Both techniques can have problems. When we think about ruptured aneurysm, right? Because of BRAT, we think coil first. An aneurysm should be coiled, coil it, done. It can be clipped, clip it, done. But that's not always possible, like this mycotic aneurysm recently. So bypass. You have to have that third option at your center to definitively treat all aneurysms. You got to use it judiciously, but you can't just use it for no reason. But when you're pressed, it has to be available. So what do I mean? We have an aneurysm that comes in that's fusiform and involves a segment in the vessel where our only option is to trap it. Well, that's not a good clip case. That's going to result in a stroke. So for the residents, for those of you going into vascular neurosurgery, you got to know bypass too. And where do you get most of your bypass cases? It's from Moya Moya. This is the way to perfect your bypass skills. This is the foundation for all of your future bypasses. This is one anastomosis. It's on the surface, it's superficial, and you're going to do a lot of STA to MCA bypass for Moya Moya. And we reported this recently in Neurosurgery Focus. Look at the number of cases we are doing in this country for Moya Moya with bypass versus everything else. Everything else is on the decline except Moya Moya. It's because our endovascular techniques are so good. Remember I told you, CC fistula, that's an endovascular case. There's no open corollary to that, right? There's no open option. Moya Moya, what's the endovascular option? There is none. It's a bypass. So that's why these numbers will continue to go up as the other case numbers go down. So why do I tell you that? Because I want to show you a little bit about STA MCA surgery for Moya Moya so you can use that for more complicated stuff, deeper posterior circulation, posterior fossa bypasses. So the most important thing about your bypass surgery, and Josh and I did a case recently, is the field has to be dry and your arteriotomy has to be clean. If you can see the bypass, if it's clean, you're going to have a patent bypass. You have to see every suture. And I'm going to show you how just meticulous and completely obsessive you have to be about seeing every single suture bite. And you want a microscope that gives you those capabilities as well. So I use 9-0 suture. We use tying instruments, and the arteriotomy has to be straight. It has to be at least 5 millimeters. I measure it every time because I want the arteriotomy to be the same for every case. Now, if your bypass is clean, your bypass will be visualized. It'll be an easier surgery and it will be patent. Now, this is more artwork from Ken Probst. This is how I suture when I'm doing an STA MCA. I do a toe stitch over here, a heel stitch over here, and then 7 interrupteds in between at 5/8 of an inch in between. So this is what the toe and the heel look like. You're basically opening up the cross-sectional area of the STA where it connects to the MCA. We have a 5 millimeter arteriotomy and a 1 millimeter vessel. So that's why we fish mouth. And what that means turning it over and extending the length of the opening in the STA so that they will have a larger cross-sectional area and flow together much better. Now, again, it's a 5 millimeter opening. These are stitched 5/8 millimeters apart so that you have 8 bites across to the other side, 16 total stitches. Now, this is what's important. Keeping the field clean, 5 millimeter arteriotomy, mark it out, fish mouth your vessel, bring everything nicely together, and see every single bite. You want every single suture line to look like this. A clean field is a clean bypass, is a patent bypass. So this is what you want to see. And with the new scopes, we can actually zoom in even further. There's no guesswork. If you're guessing about your stitch, you're in the wrong place. You need to see the stitch go exactly through just the amount of adventitia you want on the STA followed by the MCA. And that's when you know you've seen it. You're not guessing. So this is what you're doing here with every bite. And this is the result. You're going to have a bypass that looks patent and that looks clean. Now, we're going to use those techniques, right? You're going to do a lot of STA to MCA bypass surgery in your Moya practice for the residents, and then you're going to use that to step it up to things that may be a little more complicated, may require some creativity, right? Aneurysm surgery, MCA bypass, okay? Love MCA bypass for aneurysms. It's one of my favorite operations. So here's a patient, 70 years old, prior rupture, right MCA aneurysm. Now she has a left MCA aneurysm. You're not going to coil this case. You're not going to clip this case. Okay, here's her subarachnoid hemorrhage. There's her aneurysm. It's a comma-shaped aneurysm and involves her left M2, the entire trunk, and it's fusiform. You're not going to trap this and get the patient out of trouble. You're not going to coil this. You're not going to flow divert it. You're never going to make that turn with a catheter or flow divert. So what are we going to do? So you have options. You can do STA and MCA bypass. You can do a saphenous. You can do an interposition. You're not going to coil it. Not going to clip it. So bypass. So what bypass did we do? So I'm going to, for the interest of time, just jump through and skip the options and tell you that this is the outflow. This is the unaffected M2. So we just hooked them up side to side, M2 to M2. And this is what that looks like. So you're going to suture everything. Can't do interrupteds intraluminally. So the back wall has got to be running. And then this is what that looks like. These are the two M2s. This is the pathologic M2. You can see the aneurysm here, the normal M2. We're going to put the two corners together under a little tension. The first knot may have a tendency or possibility to air knot. You have to prevent that by pulling and double knotting it the first time to get them to come together. Then you're going to pass the needle from outside to inside and run the back wall. So everything on the back wall is just going to be suture. There's not going to be any knots on the back wall. And that's what that looks like, right? Because we don't want any thrombogenicity from the knots. Then once we get to the other side, we're going to take the needle, go from inside out, bring it back to the front wall. So here's what that looks like if we can get this to play. All right, so making the arteriotomy. Again, it has to be very clean. It's 5 millimeters. We're using the arteriotomy scissors here. And then basically, once we've got it exactly how we want it to look, we're going to pass outside to in, inside to out, and then we're going to tie the knot on the outside for that first anchor stitch. Okay? And then here it is under a little bit of tension. Once you got that, smooth sailing. Pass everything on the inside, get the knots to sit down, and then come back out. Pass the knot back or the needle back to the outside so that you can run the front wall and run the front wall here. And now you've got two vessels, one lumen. So now these are going to communicate. You can see that here. And this is a Sylvian fissure. This is the superior M2, the temporal or inferior M2. And here's the aneurysm. So we're just going to trap it. This is an AVM clip. We're going to just put an aneurysm clip on the M2 inflow and done. So here's the icy green. You can see them flowing together nicely. And we did an intraop angiogram just to be sure. And there it is. There's the intraop. There's the 3D. You can see the side-to-side bypass. Aneurysm's gone because we've trapped it. And there you go. So she had expressive and receptive aphasia. Immediately post-op, she was stunned by the clamp time and the operation. Obviously, she had vasospasm as well. But by the time she was out of vasospasm, she was completely recovered. I saw her back a year later and re-clipped her other aneurysm that had been clipped 20 years earlier. Still talked to her and she's intact. Another case, saphenous vein bypass. This was for a cavernous aneurysm. We don't see many of these rupture, but this cavernous aneurysm did rupture. And unfortunately, she had a PDGFR mutation. So can't coil it, can't clip it, it's fusiform. Here's our circuit diagram. So we're going to go common to saphenous to M2. We have our vascular surgeons take 30 centimeters of saphenous. We'll use that to revascularize. This is the whole hemisphere. So here's our CEA incision. We're down to the bifurcation here. And then here's our Sylvian fissure. You can see the subarachnoid hemorrhage. They got us a beautiful saphenous graft. Work with your vascular surgeons. They are so helpful. Saves you the time of getting a radial. It doesn't spasm like I stopped using radial. I only use saphenous now because it's such a good vessel. Doesn't spasm. And we have friends. We have vascular surgeons who are willing to help. So that's what I've been using these days. You can see the M2 here. So we're going to do a high flow bypass to the M2. Nice arteriotomy, has to be clean again. And then you're going to do, this one is probably 14 interrupted sutures using ADO, just because it was a big graft. You can see the saphenous. Always make sure the saphenous is flowing the right direction from the foot to the hip. That's the direction it has to flow in the head because it has valves. So don't forget about that. That could be a big problem if you do. And then just putting this in. And then all we did was proximally occlude in the neck. And there, and test your flow. 157 mLs per minute on the Doppler through that saphenous graft. And then we just did a proximal occlusion. You can see it here on the CTA. You can see it here on the post-op angiogram. We've gone around the aneurysm and we're vascularizing both ACA territories. She did well, but then her other aneurysm on the other side ruptured a year later. And unfortunately, she passed from that. Also a fusiform aneurysm involving the M1 and all the lenticulostriates. Pica is a great bypass pathology. We see a lot of pica aneurysms needing bypass because a lot of them are fusiform or dissecting in this location. So this patient was from Guam and they sacked his vertebral artery, but the aneurysm kept growing from the other vert, feeling retrograde. So 27-year-old patient flown in from Guam. We did a pica bypass, occipital to radial to pica, and then we just trapped this aneurysm. So you can see that here. There's no coil, there's no clip option, nothing. You got to bypass. And that's what we did. And so here's the far lateral approach. You can see the cerebellar tonsils. This is the vert. You can see coils in it. There are the coils that sack that vert. The aneurysm is going to be down here. Here's the distal pica. So we're going to bypass to that. You can see the arteriotomy in the pica. And then you can see the radial artery, interrupted sutures. Then we're going to bring it up. There's the radial. And we're going to bring it up and just do end to end to the occipital. You can see the flow retrograde from the pica, maybe. And just hook it up to the occipital. And there's our outcome. We trapped the aneurysm. We got a good feeling on the CTA and the angiogram, but you can see the spasm in the radial, and I've started to move away from it just because of that reason. But we did revascularize the distal pica. He did great. Although you leave the door open, so he had a lumbar drain and an EVD. It took 3 weeks before we were sure his wound was going to heal because the door is open to allow the graft to pass through. Then we reported this recently using the occipital stump. So rather than using distal occipital artery and dissecting out the whole thing, I just go to the occipital artery proximally now at the mastoid tip. So this is a saphenous graft, and there it is. There's the proximal occipital artery. This was for a similar type to aneurysm, but you can see the capacitance of the saphenous is much higher, so it flows a little bit more slowly. Here's a callosal marginal to callosal marginal bypass. Again, fusiform aneurysm. This vessel comes directly out of the dome. We just move it over and sew it to the other callosal marginal. So again, your bypass skills are going to help you with these rupture cases. And then finally, an SCA to SCA bypass. This patient was in DC, had been to Philadelphia, New York, and Boston, and then was told that there was no open option. It had to be sacrificed, and he'd probably tolerate an SCA bypass or an SCA takedown. 40 years old, he said, I don't know what's going to happen if I have an SCA stroke, and I don't want to take that risk. He flew to San Francisco from DC, and he had 2 SCAs, so I did an SCA to SCA bypass. So what does that look like? Here's this fusiform SCA aneurysm, the third nerve. We did a transentorlar approach. This is going to be the donor. This is the normal SCA. I cut this vessel off the outflow and just moved it over. So there's the arteriotomy site. Take the diseased outflow SCA, move it over to the donor recipient. Now we can see both SCAs are connected, and we trap the aneurysm. So there's the trapping, and then here is the anastomosis site. We can see the recipient, we can see the donor, and we can see there's no aneurysm, and it's been trapped. So he did well. Another case. So this was the ACD approach I promised. 50-year-old male, cervical chordoma, C4 to 6 fusion, C5 corpectomy. Dr. Chow, Dean Chow, is now at Columbia, is talking about doing a spondylectomy for this chordoma en bloc resection, but it wraps around both verts, right? So can't take both verts, you just can't. So here it is, and we got to get a bypass in distally. So we did an ACD approach with Dr. Chow. It was amazing. He got so far lateral, exposed up the whole foramen, and we bypassed to C3 with a saphenous, which I'll show you here. So we basically went above the tumor so that he could do an en bloc resection. So they're codominant. He needs them. He needs at least one. So it's a long operation. This one will definitely test your stamina, but basically this is midline. We went out laterally. We exposed the vertebral artery in the foramen transversarium, did an end-to-side anastomosis to a saphenous vein graft. Again, thanks to your vascular surgery colleagues, always. Here's the retractor. Dr. Chow was incredibly helpful getting us the exposure that we needed. And then we did, again, mark the arteriotomy, put background underneath it, and then bring in your saphenous. And so here's the opening, and then sew in your saphenous graft, which you can see here, end to side. There it is. So now we've put the saphenous into the foramen transversarium. For you residents that want to find the artery, it's there. And then we plug it into the common carotid on the other side. And now we've done a common carotid artery to saphenous to V2 bypass above the tumor. And what does that look like? Well, on angiogram, there it is flowing. And on angiogram, it looks like this. You do a carotid injection and you see the vert. So here it is plugged in right there. We're talking about just lateral on C3, okay? And there's the common carotid artery going back to the vert. And there it is plugged in right there, the foramen transversarium. And on angiogram, that's what it looks like. You do a carotid injection, you see the posterior circulation, you see the vert above the tumor, and they were able to proceed with their surgery, and it went well. So bypass gives you some options, not just for aneurysms, not just for ischemic disease, but also for some tumors. And so I would tell the residents and the fellows going into vascular that this will help you get out of trouble. When you're not even expecting to do a bypass, there may be injuries in tumor cases or aneurysm clippings of the MCA where you just have to place a stitch. Just always remember and keep those skills in your back pocket. I'm going to skip this last case. That was a malignant peripheral nerve sheath tumor that I did with ENT in San Francisco. We did a high flow bypass around the tumor, and then the bypass actually filled retrograde. So I came back with them and we removed the tumor in the neck after the bypass because it was still alive, but flowing retrograde now through the bypass. And she ended up doing well. She got a gross total resection and has been disease-free, actually, even though it was malignant. And I believe the ENT team wrote that up. So in any case, I'll go to the conclusion and take any questions you all might have. There's that case. So basal brainstem bypass, BBB, they have quite a bit in common. There's a lot of case complexity. It's something that's interesting to me that I'm passionate about. I hope the residents will be passionate about it. I hope some of you will consider brainstem surgery, bypass surgery, basilar surgery one day. These cases are recalcitrant. The numbers are getting fewer, but the complexity is getting higher. So we have that disparity to really resolve. How are we going to do that? And it really does require open fellowship. And again, it's all about passing the torch on to the residents, to the fellows, centralizing these cases into CAS programs, the 10 open fellowships that are still available. Those are the cases where you're going to see these cases and come up with new creative approaches, including ACD approaches for bypass, TQL, M2 side to side, going through lamina terminalis, SCA to SCA. Allows for some creativity, some illustration, some artwork, and some work in the cadaver lab. So this is really a theme that I am excited about. I want these cases. I want people to send these cases. I don't mind them at all. And again, important to acknowledge your mentors, your chairman. Thank you so much for the opportunity to be here, Dr. Levy, Dr. Heroes, everybody. And I'll take any questions.
I love your idea of getting the region to say, hey, let's send these down to Dr. Abla. I mean, the frustration, and I see it in my subspecialty as well, that private practitioners would much rather put one coil into an aneurysm and then send them off. You know, how do you get those people excited about sending these cases down?
Yeah, I think you have to partner with them. You don't want them to feel threatened, but you want them to feel that you're a resource. And if they can get a patient out of trouble and put a coil in and potentially get a procedure out of the case, but even if it's not completely done, and you're willing to take anything they'll send, right? A patient who's in vasospasm, who's got maybe a partially treated aneurysm, you always say yes, then I think you will start to change the perception that you're there to take, and potentially you can be there more to help. And so that's kind of the mindset that I want to get out there.
Wow. Spectacular. I think we're so lucky to have you here. It's really it's great, and I'll have to congratulate Dr. Levy for the good eye on recruiting a superstar like this. There aren't many around the country who were able to, to fish him out of San Francisco. I think that's a great cook for us in Miami. It's wonderful to have you, and wonderful to know that we're still going to be one of the 3 or 4 places around the country where this stuff can be done. So we're very lucky to have you.
Thanks.
Welcome.